Hello there. So we are here for the audio slides of this treatment of malaria. Man has got very close relationship with mosquitoes and malaria. The very same place that we are occupying today was once occupied by lots of mosquitoes and malaria, and people used to be afraid to come to this place, and this was full of jungle. And with the advent of anti-malarial drug, we have been able to build our own concrete jungle at this place. Even today, if we see it carefully, over the 1 million people who die of different parasitic disease, malaria accounts for around 85% of those deaths. That means it is more than 5 times. It's around more than 5 times all the death due to all the parasitic disease together. So it is very important disease of the world. We can save lots of life even with the anti-malarial drugs. Now this is the globe world, and these are the different countries in the globe. So if we stop the globe for a while and spread these all the country in one sheet, it will look like this. And these, and here are the blue ones are the places where there is malaria, and the non-blue ones are the places where there is no malaria. So what is the common thing between all these nations in the world which are having malaria? These all are tropical and subtropical countries. If we see carefully, these all are tropical and subtropical countries. This is the North America, or this is the North America, this is South America, and this is known as Central America, and this is Africa, and this is this is South Asia, and these are the Southeast Asia. These are the Southeast Asia, and this zone is known as Middle East. In the few countries of Middle East also there is this disease. So the common thing between those diseases are they are the tropical and subtropical countries, and this is the equatorial line, and for certain longitude, if we draw lines from certain longitude, crossing the certain longitude, then we get these tropical lines, and our countries are either tropical or subtropical countries. So what are these countries? So talking about the malaria, we see that even today chloroquine is sensitive only in this Central America and few parts of Middle East, that is Yemen and Oman, and in the most of the Central American countries like Costa Rica, Panama, Colombia, Nicaragua, Honduras, Guatemala, and El Salvador, maybe Ecuador. These countries, this chloroquine is still sensitive, and for the other countries the chloroquine is almost resistant. For everywhere chloroquine, which is the main drug of malaria, is resistant everywhere. And if we go to this Southeast Asia, which comprises of countries like Thailand, Burma, Laos, Vietnam, Malaysia, Indonesia, and Philippines, here there are multi-drug resistant malaria or multi-drug resistant plasmodium. That is, not only chloroquine, many other anti-malarial drugs are also resistant over these places. Now this is the scenario of Nepal. Kanchanpur is having the highest number of malarial cases every year, and so if the only the green ones are the places where there is no malaria, so this is very few. So we see that the white ones are also malaria endemic, and blue ones are highly malaria endemic zones. So these places we see lot of malaria. And this is in India, only this white zone is relatively free of malaria. Otherwise every place is having malaria. malaria, and the data shows that 80% of Indian population lives in malaria risk areas, and the largest number of chloroquine resistance or chloroquine failure are reported from the northeastern part of the India, that is adjoining Nepal. So it is very important. So our country is in the malaria zone. So this is the culprit of malaria, that is female Anopheles mosquito, which injects the plasmodium to the non-infected people, and they suffer from this disease. And there are mainly 4 kinds of malaria. One has recently been added, which is known as Plasmodium knowlesi. As far as the danger is concerned, this is equivalent to Vivex, and this actually that was a monkey plasmodium and is now also seen in human. So for human we have Plasmodium vivax, which is most common malaria causing organism in our region, and falciparum is the most is of the utmost important, because it is the one which leads to the death most of the time. It causes malignant malaria, the cerebral malaria, or that is severe form of malaria, or complicated malaria is most of the time only caused by falciparum, and malariae and ovale are not found in our region. So life cycle of Plasmodium from the pharmacological point of view: first, a mosquito bites a human, uninfected human, and injects the sporozoites into his blood, and that sporozoites moves to the liver, and there in the liver it undergoes schizogony or multiple fission, and multiple fission it undergoes, and it will produce more of these, and the products are known as of the multiple fission are known as merozoites, and these merozoites attack the RBCs, and in turn they grow in the RBC. These seasons, these plasmodium grow in the RBC, and ultimately they burst, and this bursting is responsible for the clinical features of fever and cold stage, hot stage, and sweating stage. This is responsible for the clinical features or clinical manifestation of malaria. And after some times some of the merozoites converts into the gametocyte, and these gametocytes, male and female, taken by another mosquito when it bites that infected human, and this infected human will then inside the mosquito it will undergo sporogonous cycle and converts it into the then converts it into sporozoites, and sporozoites are injected into a new uninfected human, and the cycle goes on. And the one thing that has to be remembered is that this is the cycle of falciparum and malariae, Plasmodium falciparum and Plasmodium malariae. But regarding this vivax and ovale, they will all of them may not come out of the liver. Few enter or remain in the body of the remain in the liver of the infected person as hypnozoites, and they don't manifest the disease at this stage, but after sometimes after a year maybe these hypnozoites which were sleeping in the liver become active and causes relapse of disease. It is true only for the vivax and ovale. Actually, the pre-erythrocytic or intrahepatic or hepatic or exoerythrocytic cycle can be used as a replacement to each other, as a synonym to each other. But here in our KD Tripathi, the exoerythrocytic cycle has been termed to the cycle which gives to the hypnozoites, that is present only in the case of vivax and ovale. So we can so according to this book, exoerythrocytic cycle is the cycle that is present only in the vivax and ovale and give rise to the hypnozoites, and later these hypnozoites may, if not cleared well, then it may give rise to this relapse of the disease. So few terms that need to be clarified. Multiple fission is called schizogony. This schizogony is nothing but the multiple fission, and schizoned means the plasmodium that undergoes schizogony, or the plasmodium that undergoes multiple fission. Merozoites are product of schizogony, and tissue schizonticides are those which kill the schizones in the liver, and they may be used as prevention of relapse with hypnozoites in case of Vivex and Obel, and they are the entry point, so they can be used as causal prophylaxis for any pre-erythrocytic schizogony, for either it is all four types. So it can be used as causal prophylaxis, that which causes prophylaxis, it can be used as that. And blood schizonticide or RBC schizonicides are those which kill the schizones or the plasmodium in the RBC. So they prevent the clinical manifestation, and if they act very fast before the appearance of the clinical signs and symptoms, they may be used as a suppressive prophylaxis. So if they are rapidly killed without the symptoms being manifested, then we can call it suppressive prophylaxis. And gametocides are the one which kills the gametocyte, which kills this gametocyte that is otherwise taken by the mosquito. And the thing is that gametocidal action is not benefit to the patient, to the suffering patient, but it may reduce the transmission to mosquito, and thereby injecting it to the next person. So we have other terms like relapse. Relapse means disease from hypnozoites even after clearing the plasmodium from the blood. So if the disease relapse or comes again after the plasmodium is cleared from the blood or RBC and if it is due to hypnozoites that survive in the liver in case of Vivex and Obel, then we call it relapse. And radical cure means killing the relapse may be relapse causing forms, that is tissue schizonticide, hypnozoites. If we kill the hypnozoites and RBC both, then this is radical treatment, radical cure, and it is true for Vivex and Obel because others do not have hypnozoites. Recrudescence is something similar to the relapse clinically, but it is apparent in falciparum, not because we have not cleared hypnozoites, but because when the blood is not totally cleared of the parasites. When the blood is not totally cleared of the parasites using certain blood schizonicides, if some amount of plasmodium remains in the blood at low level and we ignore it, it may later give rise to this recrudescence with the clinical features coming again. Now, the classification of the drug, we have tissue schizonicides. Tissue schizonicide, the primaquine is the best drug, to kill the liver forms, and proguanil is also somewhat active, but it is not a reliable tissue schizonicides. And blood schizonicides, every drug that we know except for primaquine is a blood schizonicide. So you can add lots of drug here. And gametocides, the primaquine is the reliable one, which is gametocidal to all species, and quinine, artemisinin, proguanil, and chloroquine also have some gametocidal action. Now, talking about malaria and resistance, if not otherwise specified, means chloroquine resistance by Plasmodium falciparum. Chloroquine resistant offered by Plasmodium falciparum, and multi-drug resistance means resistance against chloroquine plus any other anti-malarial drug. So so resistance, that is the one which is found except in those few countries of Middle East and Central America, and multi-drug resistance are those found in the Southeast Asia, especially in the rural or the borders of Thailand. So chemoprophylaxis, we have to bury these kinds of place where the mosquito reproduce, and we can use the net or we can use the repellents, insecticides, etc. And besides that, like for the travelers also, chemoprophylaxis is very important. So if a travel from non-malarious zone non-malarious zone wants to go to this malarious zone, then what kind of precautions should he take? Okay. To the areas without resistant Plasmodium falciparum, like Middle East, few countries of Middle East and Central America, he can take chloroquine only 500 milligram weekly. And if he wants to go to the areas with chloroquine resistant, which is the most of our places except for those two places, the most of the places, then he can take mefloquine 250 mg weekly. And if he wants to take the drug daily or the mefloquine is not available, then we can use Malaron, which consists of 250 milligram of atovaquone and 100 milligram of proguanil daily, one tablet daily. He has to take it daily. And if someone is visiting the places with multi-drug resistant Plasmodium falciparum, that is those Southeast Asian countries, especially the few borders of Thailand, then he has to take the drug for multi-drug resistant Plasmodium falciparum, that is 100 milligram daily. And if the Plasmodium vivax or oval is of concern, then you have to do this something known as terminal prophylaxis, which kills this Plasmodium oval and Plasmodium vivax this liver forms or hypnozoites. So after he returns, he will take terminal prophylaxis for Plasmodium vivax and Plasmodium oval if they are suspected. So this will prevent the infection of the individual. And we have to and for the primaquine and these drugs, except for doxycycline and Malaron, which are started 2 days before, these two drugs are started 2 days before these two drugs, and the other drugs has to be started since 1 week, 1 to 2 weeks, maybe for remembrance, 1 week. Chloroquine and mefloquine has to be started 1 week before the travel, and this can be started 2 days, or we can remember it as Malaron and doxycycline is started 2 days ahead of the travel, and these mefloquine and chloroquine are started 2 weeks before the travel, since 2 weeks before the travel, and they have to be continued 4 weeks after leaving the endemic area, and they have to be taken for 4 weeks. Even after coming home, for 4 weeks in the same dose, they will take the drug. So once again, our kind of prophylaxis, one is causal prophylaxis. Causal prophylaxis is killing the mosquito, killing the Plasmodium when it is in the liver. So primaquine is the drug of choice. And suppressive prophylaxis is to kill the erythrocytic parasites before they increase sufficiently in number to cause clinical disease. So blood seasonicides, if acts fast, then it can also be used as suppressive prophylaxis, like we have used this doxycycline, mefloquine, chloroquine and Malaron. Malaron, proguanil also have this action in the liver, but this atovaquone doesn't have. So except for primaquine, all have suppressive prophylaxis, and primaquine has this causal prophylaxis. Now heading towards the treatment of malaria. For Plasmodium vivax, oval, malariae, and for uncomplicated means patient can take orally, uncomplicated chloroquine sensitive Plasmodium falciparum. So chloroquine sensitive Plasmodium falciparum is found in the Middle East and Central America. So if one is suffering from Plasmodium falciparum, but the case is uncomplicated, and the location is in the Middle East or the Central America, then one can treat it with chloroquine, and this chloroquine is good for oval, malariae and vivax. They have not developed much resistance against it, only this falciparum has developed resistance. So this is the way in which we treat this disease. That is, we give at the easy way to remember it is we give the drug at at stat at 0 hour, then at 8 hour, and then in the second day, and then in the third day. So in the by third day you have to use 25 mg per kg. If you combine all this 25 mg per kg, you have to deplete this 25 mg per kg. And how we deplete it? In the first day we give 10 mg per kg, and in the 8 hours we give 5 mg per kg, second day 5 mg per kg, and third day 5 mg per kg again. So this is the way to treat it. And for a 60 kg individual, 60 kg individual, this 10 mg per kg will become 600 mg, and so are the 500 mg per kg becomes 300 mg for the 60 kg individuals. So we can give 600 mg stat, 300 mg stat, 300 mg stat, and 300 mg stat again. So if the tablet we have is Lariego tablet, which contains 50 milligram chloroquine phosphate, and this 500 milligram chloroquine phosphate, and this 500 milligram chloroquine phosphate is equivalent to 300 mg chloroquine base, and all here we are talking about the base, not about the chloroquine phosphate. So we have to give this drug, the drug 2 tablets, 500 mg chloroquine phosphate tablets, 2 tablets, and then 1 tablet and 1 tablet and 1 tablet. The thing to remember is that Lariego is 500 milligram tablet of chloroquine phosphate. And so this is it. And for the radical cure of Vivex and Ovel, for radical cure to prevent the relapse, we have to also treat Vivex and Ovel. So we treat it with Primaquine 30 mg for 30 mg for 14 days. This 30 mg can be given in 2 divided doses, 50 mg in the evening and 50 mg in the morning, and for 14 days. So this is the way in which we treat this uncomplicated chloroquine sensitive falciparum malaria and all others malaria. So we treat it like this with chloroquine. The main thing is to remember 25 mg per kg has to be depleted in 3 days. And how we do it is we take 10 mg per kg on the first day, then after 8 hours 5 mg per kg, and on the second day 5 mg per kg, and on the third day 5 mg per kg. And we also give for radical cure of Vivex and Ovel. So for uncomplicated chloroquine resistant Plasmodium falciparum, we have to use artemisinin based combinations. Artemisinin is in fact a drug that is taken from Chinese ancient medicine, or the and where they derive it from the tree known as Artemisia annua. So we take the drug from that tree, and this is known as artemisinin. So artemisinin, so there are different derivatives of artemisinin. So artemisinin based combination has this international standard of care today, and one available in here is Coartem. Coartem contains artemether 20 mg and lumefantrine contains 120 mg. So we give this drug. This 1 tablet contains artemether plus lumefantrine, and these tablets we have to give 4 tablets and twice daily for 3 days. That means Coartem 80 mg artemether, 80 mg lumefantrine, and it is given BD twice daily, in the morning, in the evening. So for 3 days. So altogether we are using 24 tablets, I suppose, if I am right, in 3 days. So other WHO recommended option for uncomplicated chloroquine resistant Plasmodium falciparum, that occurs in our part of the world, and uncomplicated means the patient can take orally. So these are the ones: artemether and lumefantrine we just talked, artesunate amidiaquine, artesunate mefloquine, dihydroartemisinin plus piperaquine, and artesunate plus sulfadoxine and pyrimethamine. So these are the ways in which we can treat uncomplicated falciparum malaria, uncomplicated, that can take all of these are oral drugs, so we can treat with these drugs. We don't need to remember the dose of all of them, and we can, it's adequate if we can remember it, this one dose for this one, because it is what we use here. For complicated malaria, so what is complicated malaria? If the patient cannot take orally, or if the patient have any one of these features like hepatic dysfunction, hypoglycemia, so all of these, any one of these, or decreased urine output, any one of these, then we call it the severe malaria, complicated malaria, and it is most often and it is almost always caused only by Plasmodium falciparum. So what to do with this severe complicated malaria in which patient cannot take orally? We give intravenous drug. Of course, we give intravenous drug, and the drug of choice is artesunate, which comes in this vial as well as this vial as well as this ampule. So this is ampule and this is vial. So the drug dose is 2.4 mg per kg, and we give 2.4 mg per kg. So for a 50 kg individual, we give 120 mg, and each vial contains 60 mg. So if we can give 2 vials, that is enough, and we have to repeat it. So how often? In 12 hours, 24 hours, 30 hours and 54 hours. That means this is in the first 24 hour, and then this is in the second day. If the first day is admitted, we give these 3 doses, and then we give in the second day, and then we give in the third day. So this is it. So 0 hour, 12 hour, 24 hour and 30 hour. After 6 hours of the 24 hours of the first day, then we give it at 24 hours. And the bottom line is that we have to switch over to 3-day oral artemisinin based combination. So we have to give 3-day of oral, and like we see of coartem in between, whenever the patient can take and tolerate oral medication, and to prevent the recrudescence. Recrudescence means the symptoms appearing again, because erythrocytes are not totally cleared of these C zones. So this condition, to prevent the recrudescence in this falciparum malaria, we gave 7-day doxycycline and 100 mg BD or clindamycin 300 mg QID for 7 days. So we also give this drug to prevent recrudescence. And alternative to this artesunate is quinine. We can give intravenous quinine as an alternative to artesunate, but every evidence favors that artesunate is better. Especially in the pregnant, we give quinine because we have much experience with quinine, though it is said that artesunate is safer. So I don't want to confuse. Still in our places, if the woman is pregnant, we give quinine at the first choice and artesunate at the second choice. So Bill Gates and Melinda Gates' contribution is immense in malaria. So they have been admired for their noble work. We should also clap for them. Now let's talk about chloroquine. Okay, for the drugs in individuals, particularly all the drugs, let's see the second slide, second audio lecture. Thank you.